Welcome back. We're going to conclude the respiratory lecture series by talking about respiratory patient management principles. This lecture will specifically discuss the management principles and treatment theory for the EMT Basic, focusing on the EMT skill set. It serves as a good reminder that the first step in treatment for these patients, even for advanced level providers such as AEMTs, paramedics, or physicians, is a basics first approach. So while we're not going to discuss the complete and comprehensive treatment, we will discuss the first steps in treatments for some of the most common respiratory diseases. First and foremost, when we talk about respiratory system pathologies and treating respiratory patients, if a patient has respiratory insufficiency or they're otherwise presenting in respiratory distress, we should administer supplemental oxygen. While there are a handful of side effects and considerations with the administration of supplemental oxygen, anytime a patient is hypoxic or in respiratory distress, oxygen should never be withheld. Some patients may need a CPAP or a bag valve mask device, depending on their presentation. Patients who are showing significant signs of pulmonary edema or asthma and having difficulty keeping airways open or exchanging gas effectively may be assisted with the use of CPAP, while patients who have hypoventilation or inadequately ventilating may need to be assisted with a bag valve mask device. Patients may have a metered dose inhaler or small volume nebulizer and may have used it prior to your arrival, so ensure prior to giving medications you inquire to the patient's use of those medicines. You should consult med control or your med control physician to make sure that medications that you have are indicated. Remember that as EMS providers, we practice medicine as a privilege of our medical control physician's license. And if it's not in a standing order to give a medication, we'll need to provide online medical control orders to ensure that we can administer those medications. Ensure that there are no contraindications for any of the medications that you're administering. Most medications that we use in treating respiratory patients are going to be used to relax the muscles that surround the airway passages, to dilate the bronchioles. Common side effects of those medications include things like increased pulse rates and nervousness, as well as muscle tremors. When we're talking about addressing upper and lower airway infectious diseases, always administer humidified oxygen if available. With that, you shouldn't withhold the use of oxygen if you don't have an oxygen humidifier in the truck or at your disposal. Do not attempt to suction the airway or place an oropharyngeal airway in the patient, particularly if they're conscious and awake. Position the patient comfortably and transport promptly. Respiratory patients can deteriorate quickly, and so you want to make sure that you're moving toward definitive care whenever possible. When we talk about treating acute pulmonary edema, these are patients often with a history of congestive heart failure and are presenting with that coarse rhonchi or fluid sound in the lungs. We can suction these patients if necessary, if there's fluid directly in the airway. But most commonly, the insult will be in the lower portions of the lungs, and suctioning either won't be needed or beneficial. Position the patient comfortably and provide CPAP if it's indicated and allowed by your protocols or guidelines. CPAP, if you'll remember, increases PEEP to the airways and provides pressure for the patient to exhale against. This prevents atelectasis or closure of the airways and helps force fluid from the lungs back into the capillaries for the pulmonary circulation. Transport these patients promptly. For chronic obstructive pulmonary diseases such as bronchitis, COPD, and even some considerations with asthma, assist with the prescribed inhaler. If you're allowed, you can administer the bronchodilators that are allowed by your service and med control physician. This is typically albuterol or Xopenex. Position the patient comfortably and transport promptly. Make sure that you verify the rights for your medication, for any medication that you may be administering, and you're monitoring for both the intended effects and the side effects. Asthma, you should be prepared to suction. We did mention the trifecta of asthma presentation, which includes dyspnea, shortness of breath, mucus secretions in the bronchioles, and wheezing. Assist the asthma patients with their prescribed inhaler or consider administering the bronchodilator beta-2 agonist medication such as albuterol. You may also be allowed to administer mucosal agents, antimucosal agents such as Atrovent in the form of a duoneb for asthma patients. Provide aggressive airway management and supplemental oxygen and prompt transport, as asthma can be a progressive disease and patients may benefit from advanced life support procedures and medications. With hay fever, these patients are unlikely to need emergency treatment, and the treatment should focus on supportive care. With anaphylaxis, if you can identify the offending agent, for example, a bee sting or other exposed agent that's causing the reaction, try and remove that from the patient. Maintain the airway while positioning the patient in an appropriate manner and transport rapidly. If the anaphylaxis becomes severe and the patient is showing signs of severe anaphylactic reaction or cardiovascular compromise, you should administer epinephrine quickly. Epinephrine is typically administered via intramuscular autoinjector. However, some services, because of the expense and accessibility of autoinjectors, have moved to having EMTs draw the medication up and administer the medication directly. When addressing a spontaneous pneumothorax, we're going to provide supplemental oxygen and transport promptly. These patients should be monitored carefully, as the progression of the pneumothorax can cause significant cardiac compromise. If your patient begins to show signs of cardiac insufficiency or reduced cardiac output, the pneumothorax has now become what's called a tension pneumothorax and should receive advanced life support intervention promptly. Pleural effusion. Treatment for pleural effusion requires fluid removal, and this must be done at a hospital. For these patients, you'll monitor them, provide oxygen, and transport promptly. For airway obstructions, if it's a partial airway obstruction, provide supplemental oxygen and transport. Encourage the patient to cough to see if they can expel the object on their own. For complete obstructions, you should clear the obstruction and administer oxygen. Whether this clearing occurs through abdominal thrusts or finger sweeps if the obstruction is visible in the patient's mouth, make sure that you administer supplemental oxygen following the removal of that obstructive. Transport immediately to the emergency department. Pulmonary emboli. Supplemental oxygen for these patients is mandatory. Position them comfortably, and if hemoptysis is present, make sure you clear the airway. Hemoptysis is the bloody sputum that is often seen in pulmonary embolism patients. These patients should be transported promptly, as definitive care will be needed to address the underlying emboli. For hyperventilation, make sure you complete your primary assessment and gather history. Please do not have your patients breathe into a paper bag. The symptoms associated with hyperventilation will include things like tingling of the hands and feet or contractures of the hands. This can be reversed by the patient restoring their respiratory rate to a normal state and calming the patient down and letting them breathe over time. An important note about hyperventilation: panic is often a response due to underlying critical pathophysiologies. For example, an underlying respiratory or cardiovascular event that's occurring that causes the patient to panic and hyperventilate. Do not dismiss hyperventilation as a simply psychiatric problem that can be addressed only with coaching the patient into breathing. A full and thorough assessment should be performed, and if the patient continues to exhibit respiratory distress due to hyperventilation, then ALS should be consulted. Treatment for specific environmental and industrial exposure revolves around removing the patient from the area of exposure first and making sure they're decontaminated. You'll treat symptoms of the underlying insult with oxygen, airway adjuncts, and suction based on presentation for the patient. For foreign body aspiration, make sure you clear the airway and provide oxygen and transport. And for tracheostomy dysfunction, make sure you position the patient comfortably and prepare to suction to clear the tracheostomy tube. You can provide oxygen by placing a non-rebreather mask or simple face mask over the tracheostomy tube. Never stick anything into the tracheostomy tube or occlude the tracheostomy tube device. With asthma, again, provide blow-by oxygen and consider the use of metered dose inhalers. And for cystic fibrosis, These are genetic disorders that can affect the lungs and digestive system. Our primary treatment goal will be supportive care with suction and oxygenation and transport to a definitive care location.